Today's topic of discussion will be hypertension in pregnancy, and there are four different terminologies which are used commonly nowadays to describe the hypertension in pregnancy. First, we will talk about gestational hypertension. It is defined as BP more than 140 by 90 millimeter of mercury after 20 weeks of gestation, and there will be no pre-existing hypertension, no proteinuria or end organ damage will be seen. But if hypertension is seen prior to 20 weeks of gestation, it implies chronic hypertension. And treatment includes antihypertensives. Commonly used antihypertensives are hydralazine, alpha-methyl-dopa, labetalol, nifedipine. And delivery should be done at 37 to 39 weeks, not beyond that. And second, that is preeclampsia. It is new onset hypertension with either proteinuria or end organ dysfunction, but after 20 weeks of gestation, and it is caused by abnormal placental spiral arteries that will lead to endothelial dysfunction, ultimately leading to vasoconstriction and ischemia. And risk factors include if there is previous history of preeclampsia, multifetal gestation, chronic hypertension, diabetes, chronic kidney disease, and age of the patient more than 35 years. Complications include these patients have risk of placental abruption, coagulopathy, renal failure, pulmonary edema, uteroplacental insufficiency leading to IUGR, and may lead to eclampsia and or HELP syndrome. And the treatment will be similarly antihypertensives, but in addition we are going to give IV magnesium sulfate that is given to prevent the seizure, and definitive management is delivery. And for prophylaxis, aspirin is the drug of choice. Third, that is eclampsia. It is defined as preeclampsia with seizures, and in this death will be due to stroke, intracranial hemorrhage, ARDS, and treatment includes first of all IV magnesium sulfate, antihypertensives, and immediate delivery. And last, that is HELP syndrome. It is preeclampsia with thrombotic microangiopathy of the liver, and HELP stands for hemolysis, elevated liver enzymes, and low platelet count. HELP may also occur in the absence of hypertension and proteinuria, and blood smear shows characteristic cystocytes, and it can lead to hepatic subcapsular hematoma and DIC, and the treatment will be immediate delivery. That will be the definitive treatment.